Hi guys.
Hi, how are you, everybody?
Good. How are you? Hi Raji.
Good, good. Flow
Hi.
team, the entire flow team. Hi.
Hi.
everyone.
Rajeshwari is in command and Akanksha is in command.
I have given all the command to Rajeshwari for now.
But I'm learning a lot, though. I'm taking down points and, it's very interesting.
Yeah, flow is really interesting. And Raji has made it more interesting, right?
Raji is doing excellent work.
Yeah, I agree.
It reminds me of my professors back home in India. The teaching, I really miss that kind of a teaching. Fantastic work. Both you guys are flow experts.
Thank you. Today will be a little heavy. Finally going into the beast. Screen. Can you guys see my screen?
Yes.
Yeah.
Okay. So let's get started, I think. Or you want to wait for a second?
I didn't see the cases today. Are they myeloid cases today?
Yeah.
Ah, okay.
Yeah, after the boring session yesterday of T cells, we are finally going into, the bread and butter. Right. Okay, so I saw that some people volunteered for cases.
Yeah. First is mine. I have actually seen just 2 today.
Okay.
It was busy and I might be like in and out of the conference too. I'm expecting one frozen and I might have to leave in between, but I mean, let's just get started.
Okay, all right.
Yeah. Can you make it bigger? Oh, I can do it too. Okay.
I can make it bigger, actually.
Okay, yeah, that's better. Okay. Yeah, so in this one, I see a blast population which is 50%. It is CD45 moderate and side scatter is fine. It's like where it should be. It is CD34 moderate positive, CD33 moderate positive, CD117 moderate to slightly bright positive. HLA DR is moderate positive, moderate to bright. I would say it's going a little up, but yeah, mostly moderate positive. And then going down, CD15, I think it is dim to moderate positive for 15. Then CD38 is moderate positive, and then where are we? Yeah, 15 we just did, 33 we did is moderate positive, and then 34 we did 11B negative, and then yeah, it's 13 moderate positive. Going down, it is 71 negative, 16 negative, 14 negative. We do these tubes for monocytes mostly, like 14, 16, those ones. I look at the 64 to 14 one more for the monocytes usually, and this is negative. And then where else are we? And then yeah, 64 negative, and then 11B negative, and then 56 negative. 56 is usually the aberrant markers, which is positive in few of the AMLs. And then, yeah, where are we? Okay, then these are the aberrant T cell marker, which can be present in AMLs, like CD2, and this one is negative.
अभी आ रहे हैं distress calls उनके कि मसूद ने हमें खड्डा कर दिया हमारा, तुम आ जाओ, अभी तक आ रहे हैं.
Sorry guys, I muted her.
Okay. It's CD2 negative, CD4 negative, and it's CD34 was positive. 7 is negative, and Yeah, I think that rest all we have done. 10 is negative, 20 negative, and then 9. Yeah, 4 negative, 8 negative, 90 negative, 20 negative.
Yeah.
So,
Yeah.
I would line it as an acute, increased blast population consistent with acute myeloid leukemia. And for further categorize, I think that's all I would be at. And I wanted to know, do you always do MPO tubes or cytoplasmic MPO in them, or no? Like if it is like straightforward like this, like you don't go there.
No, we don't go there for straightforward cases.
Okay.
Only if it looks biphenotypic,
Okay.
or if all the myeloid markers are negative, but we still think it is myeloid. I mean, when this tube is not conclusive, only then we do MPO.
Okay.
But different places have different practice, but some places always do MPO, TDT, and cytoplasmic CD3 default on all their cases. Some places don't. So it varies by practice.
And on this case particular, would you further like try to even categorize for Fab? I won't. I mean, for me, it was just like, just call it AML and that's it.
Oh, yeah. That's it. That's all.
Okay.
We don't do any of that by
anymore, right?
flow. Yeah. I mean, if we see monocytic differentiation,
yeah,
that
then we
mention
say
definitely.
monocytic differentiation scene.
And then
I do not know. Like
megakaryocytic.
some of my attendings still were like, it looks like like in the comment they would say like it is minimally differentiated, like it might be that and correlate. And those
no, we don't go there.
You don't, go there. Okay.
Actually,
I'm glad. I don't like to go there on flow.
yeah, even in our bone marrow reports, we don't say that anymore.
Okay.
Actually, I don't know about other practices though. Both at Hopkins and VCU, we only say AML or AML with monocytic differentiation in as far as Fab is concerned.
Okay.
We don't talk about minimal maturation without, we don't even go there anymore.
Okay, good.
Because I think the mutation panel is always positive for something or the other in all of these cases. So that's what becomes the identifier for these cases in future. We don't call them those anymore.
Okay, got it.
I just wanted to add in our at our place, we do the MPO right from the get-go. The AML usually 6 tube. The last tube is the intracellular, and that one has the TDT, cytoplasmic CD3, and MPO.
Right, yeah. So some places do that, but some places do not. That's what I said, like it's based on the practice.
So at MSK, we didn't used to do the MPO tube right from get-go, but over where I am right now, we do the intracytoplasmic, both TDT, MPO, if there is a blast population. And as Rajesh said, we do not classify according to the FAB classification. We just say acute myeloid leukemia, that person blasts on the final report in bone marrow. We would not say anything like that. We would say that monocytic differentiation, that's all that we would do.
Yeah, because also many a times by the time you sign out your bone marrow, nothing else is available. Even your fish is not back.
Right.
And the NGS takes 2 weeks from that. Cytogenetics takes a long time. So we don't always, I mean, after that, it's just, if fish is positive for something, we just make an addendum that it is like inversion 16 or 821. But if it is negative, we don't change the diagnosis. It's just like that.
Okay. And this one did not have any specific aberrancy that they can follow up in this patient after treatment or anything. So is like 11B negative is something that is useful to follow or no? Like I know in the next case there was like 4 expression and that is something that can be used. But in this case, like there was, I think 11B negative.
Yeah. So 11B negativity is not useful to follow because most AMLs are negative. Okay. Those with monocytic differentiation are positive and some others are sometimes positive, but mostly negative. So it is not something that we can use for follow-up.
So on this case, when there is no aberrancy, what do you use to follow up? Like then just like the blast is I'm just thinking of like.
No, the number, only the number. Just if it is more than 5%, we call it persistent. Otherwise, there is really nothing in this particular case. There is really nothing that can be used for follow-up flow-wise. Actually, like MRD for AML is not a real thing. It's only for BALL people use because you don't expect to see normal or TALL. You don't expect to see an increase in the normal blasts in those cases. But in AML, you can have, even the regenerative marrow can have like 4%, 3% blasts.
Okay.
I mean, although most cases we see less than 1% blasts in like long-term follow-ups, but regenerative marrows can have 3 to 4% normal myeloid blasts.
Okay.
So actually MRD doesn't really, it's not a real thing. I mean, people do it, but it's not very real unless you have some 7 or 56 or that kind of expression.
And then on day 14, day 28 marrow, is this any percentage of blast which is significant for the treatment? I know like induction ends at 14, and then those kind of things, like how much percentage is significant on those particular days, day 14?
For day 28, you should see less than 5%.
Okay.
On day 14, I don't know if there's a cutoff, but you should have, there should be a significant difference, less than, I mean, if the blast count is still more than 10%, they reinduce in our institute, but I don't know if that is the whole policy everywhere.
Okay.
Yeah, but you should see decrease in the population. Like if it was 60% or 70% in the beginning, and if it is still 30%, then that's not good.
Sure.
It should go down significantly.
Okay.
Yeah, okay. But otherwise, this one is very classic. This is a classic AML phenotype. It is 34 positive, nicely 117 positive, and it has other myeloid associated markers like 13 and 33, both bright, nicely uniform. A little bit of 15, but 15 never helps actually, and HLA-DR positive. So this is like just to show you a classic phenotype of an AML, like no confusion. So let's go to case 2.
Okay. So on this case, this blast, they had a slightly higher side scatter, and 45 was moderate. And then on 34, they are bright 34, and they have 33 moderate positive. 117 is 117 is dim to moderate positive. Then is HLA-DR is moderate positive, and then 33 I did. Where else? Okay, 15 negative, and then 33 is moderate positive. 38 is dim to moderate positive. Where else are we? Okay, 33. Then 13 is moderate positive, and then 11B, I would say subset is positive. And then, where I am? Okay, yeah, then another tube. 71 is negative, 3 is negative, 16 is negative. And then 34 positive, 14 negative, 64 negative. Again, then 11B subset positive, and then 56 negative. 34 is positive, right? Going here. Yeah, CD4 is positive in the subset, and that is important, like in the follow-up for this patient, like because aberrant blast or the residual blast from the AML would have, if have CD4, that is something we can follow up on this patient with. CD2 is negative, CD3 is negative, CD7 is negative. And yeah, CD8 is negative, CD19, 10 negative, 20 negative. So yeah, I would call it as an acute myeloid leukemia with blast from the very first gate, like how much percentage is 76% of blast with an aberrant expression of CD4 in a subset of blast population.
Okay, yeah, nothing much to add. This was also another AML. It just does not have uniform 117, but that's okay. It need not be uniformly positive. This is still considered positive. 33 is also partial, but still positive. And 11B, like a small subset, it shows dim positivity. And then CD4, a small subset, shows dim positivity. And this kind of shape, if you see, that is a problem with compensation. Sometimes they will test you on this in your exams. This is how they will show, like this, you have to adjust in your equipment to make sure that this is just straight and it's not overcompensated. So that's one interesting thing. But otherwise, it's just a classic, another classic AML. Any other questions?
On CD15, can you go to that one? I'm just always concerned about, that spray thing. Like, yeah, here, 34 and 15. So is this the background cell, like grands, maturing grands, which are there in the background, like which are 15 in the 15 plot?
So the maturing grams would ideally be here. They would be negative for 34 and they would be here. This I think is, I wouldn't call this as positive, and I do not have an explanation for this spray.
Okay.
We would actually call this negative. I think the gate is not cleaner, but most likely like a background or something, but it's the maturing grams would be here usually.
Yeah. So if you have to clean the gate, you just tighten up the blast population in the very first plot.
Here.
Okay, got it.
Here, yeah.
And you take the blast percentage also from this very first plot, right? When you report it.
So I actually take it from here.
34 versus 33.
Yeah, okay. Or anything else that is kind of homogeneously brightly positive. Like you can usually use this one too. 96% of this gate. So it's like 96% of 75%. So that would be still, still more than 70%.
Okay.
That's how we do it usually.
Okay, got it.
To make sure like we eliminate like these things.
Okay, got it.
We don't know what it is. So, but this one is still okay as a very nice population. But in the future, I'll show you cases where it's kind of mixed population, and you have to actually use other plots to get the percentage.
Okay, got it. Thank you.
Okay, moving on.
Okay, so I was taking page 3. So with this one, CD45 versus side scatter shows this blue population, and that's a little bit like intermediate for CD45. It has a high side scatter. Then following this population, it's 19 positive, and they are 5 negative, 38 positive, 10 negative, and it's showing 200 positive, which I'm not sure about it yet. And then on tube 2, it's 34 positive, 38 positive, 56 on partial or on subset positive, and 15 negative, HLA-DR positive, 123 negative. It's 7 negative, 117 positive. 71 is, I think it's negative.
Yeah, there are like these are positive.
Yeah, it's just, I think it's so much of it that it's going into the 71. So it's 71 negative. And then 11B negative, 13 heterogeneously positive, 33 homogeneously positive, 14 I'm thinking this is negative.
Okay. Yeah.
Or yeah, because I'm just comparing it to the 33. It's like the plot just beside it. That's what I thought. And then 64 negative, and okay. So based on, I thought that the 19 was an aberrant expression.
Okay.
And so it's an AML in my opinion, and I was, because of the 56 and 19, I was thinking maybe cytogenetic need to be performed, and then maybe we would find 821.
Yeah, okay, that's correct. This was an 821.
Okay.
And 821s usually have those blasts that have abundant cytoplasm with those salmon colored granules, sunset sign and stuff. So they do have high side scatter because they do have a lot of granules. Sometimes even our rods will be there. In fact, actually cells with even higher side scatter here can sometimes be blast. Not in this case, but sometimes those cells can be blast too. So we may have to extend your gate sometimes when you get it. Another interesting thing with 821 is like you will see monocytopenia. Like in this case, we don't see anything in the monocyte gate. So that's one more thing. And sometimes you can see myeloid dysplasia. So in 13 versus 16 and 11B versus 16, you will see that asynchronous maturation pattern in those cases. So I didn't put it here because we haven't discussed MDS yet. So I'll show you during MDS, but this one also had that. And then here we have this aberrant 19 expression, but this 19 is not like homogeneously positive. It is kind of a spectrum from negative to partially positive. It's not like homogeneously or brightly positive like the background B cells that we see here. And these are 38 positive, and 200 is positive on all kinds of immature cells like B, T, AMLs. I've seen it positive on all leukemias. So that carries no significance. And CD56 is important because in 821 and in many other cases, 56 expression carries a poor prognosis. So it is good to report it. And also in follow-up, it comes very handy and helpful. Other than that, this one was a classic acute myeloid leukemia, just the 19 expression, that's because of 821. And then the 71 is negative because we actually have some erythroids here that are 71 positive.
Okay.
And then what else? What else? Yeah, that's pretty much it.
Would you be able to show that plot, the 11B 16 that you were talking? Do we have it here? I know you're going to be showing it on in an MDS session, but do we have it here?
No, we don't have it here. That's a different plot. I didn't put it here.
That's okay. Okay.
Yeah, but I'll show you in the MDS session.
Okay.
Yeah.
Awesome. Thank you.
Any other questions? Okay. So then we'll go to case 4.
Okay. So for case 4, so we have a CD45 intermediate dim population, which is red, and it's showing high side scatter. So they are 34 negative, 33 homogeneously positive, 117 dim or partially positive, HLA-DR negative, and there are 15 partially positive, and 38 positive, dim positive, 13 homogeneously positive, 11B heterogeneously positive. And then there are 71 negative, is that CD3? CD3 negative, 16 negative, 14 negative, 64 negative, 16 negative, and 56 negative. And then, so they're negative for 2, 4, and then they're negative for 7, and 71 negative, 19, 20 negative, and 8 negative. And then I think the MPO was positive for this one. Yeah, they're positive. So I was thinking it is an AML, but because of 15 was there, which is a mature marker, I was wondering if it's like you know, the old classification, the AML with the Milo, with my. So well, I think it was M4. That's what I was thinking, just because of 15 and because 13 was heterogeneously positive.
13 is actually homogeneously positive.
Sorry, yeah. And 15 was positive. And I thought it was a mature marker, so that's why I thought it's an AML going towards myelocyte mature.
Okay, this is AML with maturation. That part I agree. But there is something else that I want everybody to know.
HLA-DR negative, right?
Yes.
Yeah.
And 33 is bright, right?
Yeah.
Right. Okay, APL, is it going there?
Yeah.
Okay.
So this particular phenotype you have to memorize, and you have to remember, this is the one thing that they want you to identify and alert, because sometimes in peripheral blood flow is very quick, turnaround time of 2 to 4 hours, and you want to alert the clinician about the phenotype and get them started on ATRA right away, because FISH can still be delayed. So this blast, they have a very high side scatter. Actually, they cut off the gate until here, but there is really no distinction between this population and here. It is a continuous population. It looks like this troll hair kind of thing going all the way up to the roof of the side scatter. And it has bright 33. It is negative for CD34. And these blasts typically are negative for CD34. Sometimes 34 can be positive. I'll come to that when we discuss that. And the 117 is usually positive, sometimes more brighter, but it is positive. It can be partial. That's okay. HLA-DR is consistently negative. 34 is not reliable. 34 can be positive, partial, but consistent markers here are bright 33 and negative HLA-DR and high site scatter. These three are consistent features. So when you see that combination, you have to alert your clinician that this could be APL and you have to get them started on ATRA. Even if you're wrong, it's okay. 99%, this is how APL will look like. But even if you get the clinicians started on ATRA by mistake, that's okay, because ATRA is more beneficial than harmful. There is nothing wrong in giving it to patients who doesn't have APL. So it's better to alert them. And other thing is 13, sometimes helpful, not always helpful. In a typical case, 15 would be partially positive, 11B would be partially positive, and even 64 would be partially positive, although this one does not have it. Maybe it has a dim 64, but 64, 11B, and 15 can be nicely partially positive in a typical case. Other than that, 2 can be sometimes positive in the microgranular variant. We'll discuss about that too. And MPO will be like very bright. I mean, if some people use Advia for their, most people use Sysmex, but I mean, in the last decade, Advia used to be very famous autoanalyzer in the lab, and they had actually cytochemistry for MPO in the equipment. And that sometimes helped even before flow came up, because promyelocytes have the highest MPO concentration, like 4+ MPO, even more than myelocytes and other myeloid cells like neutrophils. So that kind of bright MPO is always suggestive of an APL. So basically that's it. Always remember high site scatter, no DR, negative HLA-DR, and bright CD33. So these three things should make you think about APL. Always, yeah.
For the blast, how do you gate it? Like from the grands, there is no, like, I cannot see like where grands are ending and where it is blast are ending and grands are starting. So like while gating, like I'm just trying to learn the gating, like how do you draw this gate on it? Like,
so this particular one, I don't think there is actually anything else other than APLs. They must have ideally taken the whole thing. Okay. But in reality, sometimes you see a nice separation between two different populations. So then whatever is in the blast gate, we gate that one as blast. And then sometimes when we see the other gates, the bright 16 population and the bright 15 population would be mature neutrophils. And then they include everything in the gate and then they backgate it to eliminate that.
Okay, got it.
Yeah, but those are the methods. Okay, any questions?
So CD34 doesn't have to be negative in APL, right?
It doesn't have to be negative. In a typical case, most common situation is it's negative, but don't go by that. It can be positive.
So automatically, if it's an HLA-DR negative, we're like going towards APL, or we're thinking towards APL?
HLA-DR negative and bright CD33, high site scatter.
Okay.
Yeah, because there's one other entity that is very confusing with APL. Yeah. I'll discuss it today.
Okay.
But you need all, these three things together should make you suspicious of APL.
Oh, because I think most of the time, like in a clinical setting, we're waiting for FISH in order to confirm, right?
Right. Sometimes we even see by morphology and alert them. Even in the middle of the night when the flow lab is closed, we look at Cellavision and tell them that this looks like APL, we're on call.
Okay.
But when during the day when the flow lab is open, and in some places, if like the clinicians didn't call you, you didn't suspect it, this is the first thing you're seeing, then it's better to alert them based on the flow.
Got it, okay.
Yeah. And also you don't
have to wait for FISH. I mean, yeah. You can go with either morphology or flow cytometry. That's very, very important.
Okay, yeah.
They'll wait for FISH to start arsenic, but for ATRA, they don't have to wait because they can always stop it. They don't.
Exactly.
Right. Okay, so this one.
Okay, so I was taking case 5 as well. So with this one, it's a CD45 intermediate high site scatter. 33 is brightly positive. 34 is like positive on subset, or it's heterogeneous. We can see 117 is partially positive, HLA-DR negative, and then 15 negative, 38 dim positive, 15 negative, we said. 33 is heterogeneously positive, 11B negative. And then if we go to the next tube, 71 negative, 16 negative, 14 negative, 34 is partial. Okay, 56 negative. So, and with the last tube, we see the T cell markers 2, 4 are negative, 3 negative, 7 negative, and then 8. I'm just trying to see 8. 8 should be negative, 10 negative. So just to buy, just as we were discussing with the high side scatter and HLA-DR negative and 33 positive, I'm thinking that this is also an APL.
Okay.
But there was something about 2. Was 2 partially positive?
Right, yes.
Yeah, so it's a microgranular.
Yeah, you can have that in microgranular variant, but I mean, you don't have to say all that. And if you think like this, that this does not have the typical phenotype for APL, you're not confident, or you don't want to commit to it, you can always say suspicious for APL. They will still give ATRA.
Yeah.
You don't have to be 100% sure, because APL is a fish diagnosis. You can only be suggestive by flow. So you can say highly suspicious for APL or suspicious for APL, cannot rule out APL. All these things help them to, they just need something to get the patient started on ATRA. So you can use all that, but this is also an APL case. This was a microgranular variant. It has a high site scatter. It has the bright CD33 and negative HLA-DR. So this was also an APL.
And I think the microgranular is more known to be positive for CD34.
Right, yes. It can be positive for CD34, and it also is commonly positive for CD2. I mean, you won't have a bright homogeneous positivity. The partial CD2 positivity is always seen. And this one also has like a dim CD7 positivity, which is very unusual in APL, but this one had. And like if you see in this case, 11B, 64, and 15 does not help, right? I mean, they're all negative. 64 may be a dim positivity, but they are like mostly negative. So all those things does not help. So those are not very reliable. Your reliable one is bright 33, HLA-DR, and high site scatter.
Okay. One thing I had to ask, NPN1 mutation ones are 34 negative, DR negative, 33 bright ones.
Right.
I know, and they are 123 positive. I mean, on these plots, like how do you differentiate, like if there is not 123 done for them?
Site scatter.
Site scatter.
Site scatter. Yeah, yeah, we'll discuss.
I think there is one case, probably. I'm not sure.
Yes, there is one case. Yes.
Okay.
Okay. Yeah, that is the differential diagnosis for APL actually. Yeah, who's going to go with this one?
Can you hear me?
Yeah.
Okay. Hey, this is Priya.
Hi, Priya.
Okay, so I can take this one. So here in the site scatter CD45 plot, we see 46% blast and increased monocytes at 20%. The blasts are CD33 positive, CD34 negative, CD117 positive, CD38 negative, CD117 positive, HLA-DR negative, CD33 positive, yeah, CD33 positive, I said that already, HLA-DR negative, 15 negative, 38 negative, 33 positive, 13 negative, 11 11B, 11B negative. And then here again, CD71 negative, CD3 negative, 34 negative, 16 negative, 14 negative, 64 negative, 14 negative, And yeah, HLA-DR negative, 15 negative, 56 negative. And then here we see the T cell markers are all negative.
Okay, and the B markers are also negative.
B markers are also negative.
Yeah, so what do you think?
Okay, so is there not more? I think there's more, no?
Sorry? No. Okay, sorry.
It's okay. So here we're getting on the monocytes, and the monocytes are CD14 positive, 64 positive, 34 negative, 56 negative, 64 positive, 11B positive, just basically normal monocyte population here.
Okay.
Okay, so here I thought we have CD33 positive, CD117 positivity increase within the blast gate, but all other mature T cell are negative, B cell markers are negative, with increased monocytosis. So I was thinking along the lines of CMML or AML with monocytic differentiation. So
okay, so you thought of CMML because the monocytosis was high, but once the blast percent crosses 20%,
right, okay,
it is not flow is not the ideal one to get the blast percent, but when you see 46% by flow, it's more or less going to be the same in your whatever morphology specimen you're using, like blood or marrow or whatever.
Yeah.
So that's a lot.
Yeah.
So it has reached the AML arena already, right. But the monocytosis is like interesting and nice to see. Mm-hmm. And so, okay, so in AML, do you have a particular thing that you would favor?
So with monocytic differentiation.
So your blasts don't have any monocytic markers, right? So mm-hmm. The blasts do not have 11B, they don't have 14 or 64. There is a monocytosis component, but your blasts itself do not have a monocytic differentiation, right? I mean, you can say that there is really no good separation between the blasts and the monocytes. And in the monocyte gate, we also see this population that is negative for 14, which could be immature monocytes. They are positive for 64. They're positive for 11B. They're positive for HLA-DR. So there is an immature monocyte component. We don't know whether they are pro-monocytes or just immature monocytes, although I would favor an immature monocytes. But the blast itself do not have a monocytic component. So yes, when you see something like this, you can consider, AML with the monocytic differentiation that is possible. But this particular phenotype, having bright 33 with negative HLA-DR and having this monocytosis, it's more in favor of an NPM1 like phenotype. This was an NPM1. But you don't have to say that in your diagnosis. It's just for you. And you have to just differentiate this from APL. So the monocytosis and low side scatter helps differentiating from APL. The monocytosis need not be there all the time. But this one is, the blast itself are just myeloid. The blasts do not have a monocytic differentiation.
Raji, I was clear on these blasts that they do not have monocytic differentiation, but can you explain what do you look on those monocytes for the immaturity? Like what pattern do you see for that? Can you just go over that?
So if you see in the monocyte gate, we have this population that is positive for 64, but this is negative for 14. But they have other monocyte markers. It is 64 positive, 11B positive, negative for 34, and so it has the other monocyte markers. I would say it is 33 positive also, right? 33 positive. So it could be immature monocytes.
So immaturity is based on, you're saying that there is kind of two population and one is negative for 14, right?
Yes,
like,
yes.
Okay, got it.
Yeah, yeah. Okay. Any other questions?
So in NPM1, do we always see that CD117 and CD34 negativity?
CD34 negativity is consistent pretty much, and HLA-DR negativity is also consistent from what I have seen. But 117 was variable. But it does have a myeloid phenotype.
When you say myeloid phenotype, which markers are you looking at?
Like the 33, 13.
13, okay.
Yeah, this one is negative for 13, but it does have those myeloid-associated markers usually. Mainly, it's the reason that this is important is because it comes into the differential of APL because of its Pride 33 and HLA-DR negativity and CD34 negativity. We use side scatter to differentiate it. But if you still cannot rule out APL, I mean, you will also have a peripheral blood smear by this time. You can compare the morphology. You might see the cup-shaped nucleoli, or the fish stoma-like nucleoli. But if you're still not confident, if the blasts have that butterfly shape or the bilobed shape, then you can still say APL not ruled out.
Okay.
That's okay. But just make sure you don't miss this phenotype.
I just had one question. In our practice, we don't usually gate ever on monocytes. Like, you know how with your last tube, you looked at the monocytes separately. Is that a practice at your institute?
You don't gate separately on monocytes, means?
No, we never look at the monocytes. You know, if you go to the last tube here, you looked at the monocytes and you looked at, so all the gates are gated on monocytes. So we at our institution, we never do that. Like, we never look at the monocytes. It's only blast or lymphocytes. So is that normal for you guys? Like, do you guys?
Yeah. In both the places that I worked, we did gate on monocytes.
Okay.
Yeah, and we did have a separate plot just for them, and it did have this 56 HLA-DR 33 14 64 11B.
Is that a practice with an AML that you usually do?
Yes, all myeloid cases, not just AML. Okay. Anything that we run our myeloid tubes on, like CML or anything.
You have a
peripheral blood or for myeloid. Any myeloid panel we do, we have this page. We have this template.
This template as a Lismod file. Okay.
Right.
Got it. Okay. Interesting. That's helpful. Okay.
Okay. Yeah, I think most places do that. Just to make sure all monocytes are behaving.
Normally.
Yep. Okay. Yeah, most places do that.
Okay.
Yeah, okay. Yeah, did anyone volunteer for this?
No, we haven't.
Okay, so just go over it. Like, somebody can go over it now as I scroll down the screen.
Okay. I'll start.
Sure. Okay.
All right. So we have so looking at the blast population, it's STIM CD45 low side scatter. They are 34 positive, 33 positive, 117 positive, HLA-DR partially positive, and 15 negative. I'm not sure what this tiny, but I'm thinking it's just like the gating need to be tightened. 38 positive, 13 positive, 11B negative, and then 71 negative, 16 negative, 14 negative, and we're seeing that compensation problem. 64 negative, 56 negative. So far it's 33 and 13 positive that were established on a 34 HLA-DR positive population, and 117 positive. Okay. And then we are at this page, yeah. So we're 2 negative, 4 negative, 7 negative, 3 negative. So all the T cell markers are negative, 8 negative, and B cell markers are negative, 19 and 20. And then this last one, are we looking at grans? Oh, okay. So the granulocytes, it's the 60, some partially 16 positive, partial 16 negative, 13 positive, 11B positive. So the pattern looks abnormal to me for the maturation. I don't know.
Okay.
64 and 14 is on subset.
But it's probably merged a little bit with the monocyte gate.
Yes.
Yeah,
Yes. So actually, like, not all of the cells that we see here are granulocytes. I think the gate is not cleaner.
Yeah.
These probably are the mature neutrophils, but these cells are probably just monocytes because they are positive for 14 and 64, and they have this bright 33 with HLA-DR. So it looks more like contamination from the monocyte gate. Yeah.
Okay. So, this is the last one. So the monocytes are 1464 positive, 34 negative, 56 negative, 11B positive, HLA-DR positive, and yeah, so they're and 13 negative. I don't know, that looks, and 16 negative. So the monocytes, I'm not sure about this these trails, but they look, I'm not sure about 13 and 16, but it looks normal to me.
Okay, yes, they're mostly normal. Yes. Like I said, there is some mix-up between the granulocyte and monocyte gate. So
kind of shifted
this one is not like very crisp. So
right. So,
okay, but the monocytes are largely normal.
Normal, right? And then of course the granulocyte also, we couldn't see much, but then whatever the expression was on the granulocytes, it wasn't really prompting anything abnormal. So I don't know. That's what I thought. And then so for the blasts, because just because they're 34 positive, HLA-DR positive, 117 positive, 13 homogeneously positive, 33 is heterogeneous. I was thinking that it's an AML, but okay. I don't know. I'm not sure if any differentiation or anything. I'm just thinking it's an AML.
Right. So this one was an AML, like you said. Yes, just the blast did not show any differentiation, but there is a very there is a population of monocytes that are increased and they're normal. They don't have any abnormalities. So this one actually in fish, it had inversion 16. So this is one part. In this one, we have to actually mention the increased monocytes, even in our top line. This much percent blast, this much percent monocytes without any aberrant expression, we say that. So inversion 16 can have different, it is associated with monocytosis. It can have blasts with monocytic differentiation, or it can have two populations of one population of blasts with just the myeloid expression with like this one, and then it can also have another percentage of population of blasts that have the monocytic differentiation, or it can just have mature monocytes and myeloid blasts. It can have these combinations. So this was one combination where we had a pure population of monocytes and pure population of blasts. So just wanted to show that. You don't have to predict this, but it is important to mention the normal monocytes, increased normal monocytes in your report.
In this one, kind of when there is trickling population everywhere in every plot, is it like because it is not tightly gated?
Yes, it is because it's not tightly gated. Actually, some places after they gate, they clean up. But here we don't do that. We just leave it like that just to, just to make sure we don't lose anything. So that's.
And on CD2, like on this one on CD2, there was a little bit like kind of positivity. Do you go there? Because like these are the marker which might be helpful for follow-up. So will it be negative for you or is it some positivity to it?
We will still call it negative because this is like too low, just 3%. We don't really know it is actually positive or it's just the population. We don't really call this 2 as positive.
Okay. And on the monocyte 14 and 64 gate on this one, I'm just trying to correlate with what you said last time that 14 negative and 64 positive is an immaturity marker. So
okay. So this Right, that one I did say that, but here I think there is a nice separation between the blast and the monocyte population. And we did see that in the granulocyte gate, and the monocyte gate, how close they are. So we have granulocytes can be positive for 64.
So it's mostly.
So I would think those are mostly granulocytes, just based on how the monocyte population is distinct here.
Okay.
Yeah.
I just have a question. Isn't the inversion 16 we have abnormal eosinophils seen?
Yes, you will see abnormal eosinophils.
You know those granulocytes, it's distorted on 45 versus side scatter. I'm just thinking, could those be eosinophils actually?
So eosinophils actually usually they are in this area. I think that's not even gated here.
Yeah, it's not gated, but I'm thinking whether these actually are our eosinophils.
Oh, these ones. I would favor monocytes because of the 14 and 64. Majority of the cells have 14 and 64. EOs can be here. They don't have, like they usually are with, they are 13 positive, DIM 16, and they have the higher side scatter and they usually sit here. I think there is a population here, but that was not even gated. So
okay,
I don't think there are EOs in this plot.
Okay.
Okay, go to the last one. Yeah, anybody wants to try?
Well, if there's no one, I can try.
Yeah, go ahead.
So I didn't review the case before, but let's go with it. Looking at the site scatter and CD45, looks like there is a blob here. This maroon population appears to be increased and it's like DIM 45. So I'm concerned about that population. And then lymphocytes, maybe some increase in monocytes, and there is some degree of maturation as well in the granulocyte area. Then going down. So there is a prominent CD34 positive population, which is also positive for CD38 and negative for CD56. It's kind of heterogeneous expression of HLA-DR. And I think this is positive for 123 and 34. I mean, more positive of 34, maybe partial 123 there. And goodness gracious, I don't know. Okay, this is again 34 positive, 117 positive, 71 negative, 30. Okay, this is probably another tube where again we have a clear expansion of DIM CD45 positive population. There is a bright CD34 positive homogeneous population, yeah, which is again seen here, positive for 45 and 34. Negative for 11B, bright expression of CD13, partial 33, partial 14, partial 64, heterogeneous HLA-DR, 34 positive. Okay, so 33 and side scatter. It looks more like a heterogeneous, but I don't know, this is sort of difficult for me to say with all these colors. I would leave that to Raji. And then DR is also sort of heterogeneous, and we have DR and 33 positive population. I mean, at the right corner, yeah, exactly, that arrow where she's showing, I'm sure that's the monocyte population. I think. And then the same population is again bright positive for 11B and HLA-DR. So that again shows the monocytic differentiation in that population. Again, 14 positive, 64, they're strikingly standing out there. Again, DR positive, 64, 11B. The 15 bright, sorry, the 16 bright, or is it 15 or 16? 16. The 13 bright and the 16 bright is definitely the mature granulocytes. And again, you have the 64 positive monocytes, but are they showing some expression of 13 also?
Which one?
I'm just surprised. Are the monocytes showing some expression of 13? Because here they are.
Yeah.
Right top. Okay.
Yeah.
Okay.
Yeah, okay. So what do you think?
Well, I wasn't clear about this plot, this maroon plot, 45 and 34 positive. The second one there.
Mm-hmm.
What cells would they be? 45 and 34 positive. Yeah, I think it's more like a 45 dim. If I take it as 45 dim and 34 positive, that's certainly a blast population that's standing out.
Okay.
And then it's showing monocytic differentiation. It's more like a monoblastic.
Okay.
And it's, I mean, DR 11D from what I remember from before.
Okay, so what will be your diagnosis?
Am I going more towards M5?
Huh? Sorry?
M5.
M5. You mean
monoblastic or monocytic
differentiation. Okay. Anybody has anything else to add or any comments before we discuss?
I thought the mono markers were negative. Were they like 14 and 64?
I mean, this 14 was actually negative in our lab, but it does look a little positive just by looking at it, and I didn't put the controls here. So I wouldn't blame her if she called it positive.
No, yeah, they do. They do look
right, yeah.
partially positive, and then 64 partially looks positive as well.
Right. So it's,
yeah,
it does look like that. So
okay. I actually prefer with the control.
Exactly.
Yeah, but it's easier for me.
Yeah, I agree. And then 33 was
actually, if you see in this one, you can see that better. Like the maroon population is here, and you see the 14 positive population is actually here, and the blasts are negative, and even here 64 positive is here, and the blasts are negative. Even here, the 64 positive is here.
56 positive? Sorry, I haven't seen it before.
56. Where is 56?
It was 56 positive in one of the plots.
All right.
I
thought it was negative. Negative.
Oh, sorry, this is negative. I'm sorry. It's 38 positive.
Yeah, 38 positive. I know it has too many colors. Some people like to paint it so much, but I think like if we slowly take one by one, we will be able to understand. So let's go one by one. You see that these populations are all clumped together. There is no real separation. There is a population in the monocytic gate. There is a population in the granulocytic gate, but whatever is in the blast gate does not separate itself well from either the granulocytes or the monocytes. So then we have different markers here to help us. Site scatter versus CD34 gate, we can see a population that is clearly positive for CD34, and that population is also positive for CD38, it's negative for 56, it has HLA-DR, maybe a DIM 123, it's positive for 117. So we know it's myeloid, it has partial aberrant CD7. I think the maroon color, they colored it only because of the CD7. But anyways, so Myeloid blast, we have that part we are clear. Then this is another tube where we have additional markers, like the monocytic markers. So what they actually had done is like they painted everything here in this area as this light gray color, like bluish gray color. Then whatever was CD34 positive, they colored it brown, and whatever was positive for 14 and 64, they colored it this orange, and whatever was negative for 14 but positive for 64, they colored it crimson. And then whatever we see now in the bluish grays are the leftovers that they, like from the beginning what they did. So basically they backdated the whole thing, which is why we see a whole mess here. But actually, like in individual plots, it becomes better visible. So we have a population of CD34, like what we saw in the previous plot. If we trace it, it's negative for 11B. It doesn't have 14. It may be having a dim 33. It is positive for 13. It is negative for 64. It partially HLA-DR positive, negative for 10. So it still has another, still is like myeloid. It has 13. And it doesn't have the monocytic markers yet. And then there is a population here, the orange population, which are clearly monocytes, has the brightest 14 and 64, and that one also has bright 33. And it has 11B, it has HLA-DR, so those are monocytes. But then there is a population that is 64 positive, that is negative for CD14. And that one also has CD33, HLA-DR, and everything else looks like the monocytes, and it has it is negative for 11B, it has 13. So those are the immature monocytes. So when you see your blast population, the blast population is actually continuous with the immature monocytes, and that continues to monocytes. So you can actually see that in all the plots now. So if we see site scatter versus 33, you see the blast population continues with immature monocytes to bright monocytes. And again, even in this site scatter versus CD45, you see a blast population, then immature monocytes, then monocytes. Kind of even here, we see the aqua population is what is CD34 positive, and then we have this population, and then we have the monocytes. So actually you see a spectrum of your blast merging into the monocyte gate. So this one was another inversion 16 case, but you have to just say AML with monocytic differentiation, because you do see a population of immature monocytes here.
That's right.
So here you have like two different populations. One population that is 34 positive and has myeloid expression, and another population of immature monocytes. So this is also how inversion 16 can present. And actually this presentation is common than the previous one that I showed. But you don't have to predict inversion 16. That's completely by FISH, or if you see your eosinophils with those purplish granules. But in flow perspective, you have to just say that you see a population of 34 positive blasts and another population of immature monocytes. So consistent with AML with monocytic differentiation. That's what you have to say in your flow.
Yeah, but I actually correct. I mean, the different approach that we do is like in WashU, we try to mention like AML with monocytic differentiation, and in the absence of recurrent cytogenetic abnormalities, it would be best classified as blah blah in M4, or sorry, the M5A or B.
Yes,
that's how we do. So
right.
Yeah, so after the doing the FISH, you get the thing. But definitely, if we have those characteristic eosinophilic granules, we mentioned that. I mean, suspicious of inversion 16.
Yeah. You can say that in your comment in your final bone marrow report. Still, we are waiting for FISH. So you can say that it is suspicious, correlate with FISH. But you will see this nice population where you have the blast blending into the monocyte gate, actually.
That's correct.
So for this one, we are going to, like in MSK, we used to say like top line would be two things. First, abnormal myeloid blast population seen, and the second, abnormal immature monocyte population seen. And then we would describe both the things. And as Priya said, M5, I don't think it is M5, I think it is M4, and that's what is seen within version 16 as well. So that's what we call it M4EO, because it's M4 with abnormal eosinophils. So that's what we see over here. There's a blast and there is a monocyte population, and that's more of M4 rather than M5. Nice cases, Ravi.
Sorry?
Very nice cases.
Oh, thank you. Thank you.
Thank you so much.
And actually, these cases become much more challenging when there's also dysplasia in these cases.
Oh yeah,
Like,
oh yeah, agreed.
That takes it to a different level. I mean, we have to thoroughly go by morphology, and it becomes more difficult actually with the abnormal nuclear lobation, granulation. You don't know if it's monocyte or myeloid. And those, I mean, all areas are very tricky.
Yeah, anything with monocytes are hard. It takes, it takes easily like an hour or two.
Actually, the presence of those characteristic morphologic features makes our life easier. The inversion 16, 821, and those, I mean, PML and everything, when they are classic.
Right,
but
right.
Those mixed varieties with dysplasia makes it more challenging.
Yeah.
And ultimately at MSK, we just used to say acute myeloid leukemia with -% blasts. We didn't, like everything else is more of cytogenetic, everything else is more of fish. We didn't used to really like to classify. At all monocyte differentiation, as I said, then we can say a monocyte differentiation, but not really, like we don't have to commit to anything or anything.
Yeah, I mean, that has been my practice also, wherever I have been. We never commit to anything other than monocytic differentiation, or like rare ones like megakaryocytic. Otherwise, just AML.
Yeah.
I mean, if it is a myeloid dysplasia related changes, that's a different story. But even for that, we wait for fish and everything to be negative before we call it AML MRC. Because you can see dysplasia in other things like 821 or inversion 3 or other AMLs.
And MRC, correct me if I'm wrong, but MRC is more of, like when there is a prior history of MDS, or if you have 50% or more abnormal blast. I mean, flow per se is not the one that you use for MRC.
No. I'm not saying flow. I was saying about the final bone marrow report.
Right. Yeah, exactly.
Yeah,
so
yeah.
That's an entirely different beast.
Yeah.
All right.
Cool.
Awesome. Thank you so much.
Okay, so tomorrow's cases, I'll try to put it before noon.
Perfect. Thank you very much for doing all this hard work, Raji. Thank you.
Thank you.
Yes,
Thank you all.
thanks a lot for the classic cases.
Thanks.
Awesome.
Bye. See you guys. Bye.
All right. Bye-bye, guys.
Bye.
Bye.